If you had bariatric surgery, lost the weight, felt like you finally had it together, and then somewhere in your 40s, your body started doing things that made absolutely no sense, this video is going to feel like someone finally turned the lights on. Weight coming back in places it never was before, cravings that felt nothing like your old hunger, sleep falling apart, energy gone, and every provider you saw looking at one piece of the puzzle, but nobody was looking at the whole picture. Today, I'm going to give you the whole picture, and I am going to do it from two angles. As the RDN who works with women navigating this every single day, and as a woman who is personally in perimenopause and has been on a GLP-1 for the past year and a half, I know this intersection from both sides of the table. I'm Tradena Rayner, a registered dietitian nutritionist, and this is a Real Talk Nutrition where bariatric and GLP-1 nutrition meets real life. Let's get into it. I want to start with the client. I'm going to call her Michelle. Michelle came to me about 2 years ago, 7 years post-gastric sleeve. She had lost over 100 pounds after her surgery and kept most of it off for the first 4 years. She was doing everything right, hitting her protein, staying active, going to her follow-up appointments. Then around year 5, things started shifting. Slowly at first, a few pounds back, then a few more. Her hunger felt different, not the soft, manageable hunger she had learned to work with post-op, but something more urgent, more chemical. Her sleep started breaking apart. She was waking up at 3 a.m. regularly. Brain fog started creeping into her work days, and the weight that was coming back wasn't distributed the way her original body weight had been. It was settling in her midsection in a way that felt completely foreign to her body. She went back to her bariatric surgeon. He checked her labs, said everything looked fine, and told her to tighten up her diet. She went to her primary care doctor. Same story. Labs look okay. Maybe try tracking your food again. Nobody asked her one simple question. When did your period start changing? Because the answer to that question would have told them everything. Michelle was in perimenopause, and perimenopause was colliding with the bariatric anatomy in ways that none of her providers were trained to see together, and that's why we're talking about this today. Before we go further, I want to make sure we're all working from the same definition because perimenopause is one of the most misunderstood and underdiagnosed phases of a woman's life. Perimenopause is not menopause. Menopause is a single point in time, 12 consecutive months without a period. Perimenopause is a transition leading up to that point, and it can last anywhere from 4 to 10 years. For most women, it starts somewhere between their late 30s and mid 40s, though many don't recognize it until symptoms become impossible to ignore. Here is what is actually happening hormonally during perimenopause. Your estrogen levels stop following a predictable monthly pattern and start fluctuating wildly. Some months, estrogen spikes higher than it ever did in your reproductive years. Other months, it crashes. This unpredictability is what drives the symptoms, and it's also what makes perimenopause so difficult to diagnose from a single lab draw, because your estrogen on the day of your blood test might look completely normal. Now, here is what estrogen actually does in your body beyond reproduction, because this is where it gets metabolically significant. Estrogen regulates insulin sensitivity. When estrogen is stable and present, your cells respond efficiently to insulin. Glucose gets into your cells, gets used for energy, and you feel good. When estrogen starts fluctuating and dropping, insulin sensitivity decreases. Your cells become less responsive. Glucose stays in the bloodstream longer. Insulin stays elevated longer, and elevated insulin is a fat storage signal, particularly for visceral fat, the fat that accumulates around your midsection and organs. Estrogen also plays a direct role in muscle preservation. There are estrogen receptors in your muscle tissue. When estrogen is present, it supports muscle protein synthesis, the process by which your body builds and maintains muscle. When estrogen drops, muscle loss accelerates. This is why perimenopause women who are doing everything the same as they did at 35 start losing muscle mass and gaining fat even without any change in their diet or exercise habits. The hormonal environment changed. The rules change. Estrogen regulates your appetite hormones, specifically leptin and ghrelin. Leptin tells your brain you're full. Ghrelin tells your brain you're hungry. Estrogen keeps this system balanced. When estrogen fluctuates, this signaling becomes dysregulated. You get hungrier, fullness signals come later or not at all, Cravings, particularly for sugar and refined carbohydrates, intensify because your brain is looking for fast glucose it can use efficiently when insulin sensitivity is compromised. And estrogen affects your sleep architecture. It plays a role in regulating body temperature, which is why night sweats and hot flashes disrupt sleep so severely. It also interacts with serotonin and GABA, neurotransmitters that support deep restorative sleep. When estrogen fluctuates, sleep quality deteriorates, and poor sleep is not just an inconvenience, it is a metabolic event. We'll come back to that. So, when Michelle's estrogen started fluctuating, her insulin sensitivity dropped, her muscle preservation slowed, her appetite signaling became unreliable, and her sleep fell apart. Every single symptom she was experiencing had a direct clinical explanation, but nobody had connected the dots. Now, here is where it gets specific to women who have had bariatric surgery, because this is the layer that Michelle's providers were completely missing. Bariatric surgery, whether that's a gastric sleeve, a gastric bypass, or another procedure, permanently alters your digestive anatomy, and those anatomical changes affect how your body processes nutrients for the rest of your life. Not just in year 1, not just in year 3, for the rest of your life. Let me break down the 3 most significant ways that bariatric anatomy interacts with perimenopausal metabolism. The first is protein absorption. Post-bariatric patients already have a more complex relationship with protein absorption than people who haven't had surgery. Your altered stomach size, and in the case of bypass, your rerouted digestive tract, means that the protein you eat doesn't follow the same absorption pathway it would in someone with standard anatomy. Now layer perimenopause on top of that. Estrogen loss accelerates muscle breakdown. Your body demand for dietary protein to maintain muscle mass increases, but your ability to absorb that protein efficiently is already compromised by your surgical anatomy. You're being asked to do more with less, essentially. The protein targets that were appropriate for you in year 1 of your bariatric journey are very likely not adequate for where you are now in perimenopause. I see this constantly in practice. Women who have been faithfully hitting 60 to 80 grams of protein per day for years, which was absolutely the right target post-op, come to me in perimenopause, losing muscle, fatigued, and wondering why their body composition is changing despite their consistency. The target moved. The hormonal environment changed the requirement. The second is micronutrient absorption in the perimenopause gap. Bariatric patients are already at higher risk for specific micronutrient deficiencies. B12, iron, vitamin D, calcium, magnesium, because of altered absorption in the gut. This is why bariatric-specific supplements and annual lab monitoring are non-negotiable long-term. But here's what most bariatric follow-up care doesn't account for. Perimenopause creates its own micronutrient demands. Magnesium becomes critically important for sleep quality, cortisol regulation, and insulin sensitivity, all of which are directly affected by perimenopausal hormonal shifts. Vitamin D plays a role in hormonal regulation and mood. B vitamins are essential for energy metabolism and neurological function, and perimenopause affects both. When you are a bariatric patient in perimenopause, you have 2 simultaneous sets of elevated micronutrient needs that are compounding each other. Your standard bariatric supplement protocol from year 1 almost certainly needs to be revisited. Michelle's labs, when she came to me, showed low normal vitamin D, borderline B12, despite supplementing in magnesium levels that weren't being tested at all, because magnesium isn't on a standard bariatric follow-up panel in most practices. We adjusted her supplement protocol, and within 60 days, her sleep started improving. Sleep was the first domino. The third is the cortisol and stress response. Less talked about, but critically important. Perimenopause dysregulates your HPA axis, the system that controls your cortisol response. Cortisol is your primary stress hormone, but it also plays a direct role in blood sugar regulation, fat storage, and inflammation. When HPA axis function is disrupted by fluctuating estrogen, cortisol patterns become erratic. You may have higher baseline cortisol throughout the day. You may have cortisol spikes at night, which is what's causing the 3 a.m. wake up that so many perimenopausal women experience. When you wake at 3 a.m. and can't get back to sleep, that is often a cortisol spike pulling you out of deep sleep. Your liver is releasing glucose in response to that cortisol. Insulin follows. You are in a fat storage cycle in the middle of the night. For bariatric patients, this matters because chronic elevated cortisol also impairs gut motility and absorption, which means the already altered absorption landscape of your bariatric anatomy is being further compromised by stress hormone dysregulation. This is a complex picture, but it has solutions, and that's what I want to get to now. I want to shift for a moment and speak personally because I think it matters for you to hear this not just from a clinical perspective, but from someone who has lived it. I am in perimenopause. I have been navigating this transition personally, and I have been on a GLP-1 medication for the past year and a half. I am not sharing this for relatability points. I'm sharing it because when I started experiencing the symptoms I just described to you, the sleep disruption, the changes in body composition, the way my hunger signal shifted, I had the clinical knowledge to understand exactly what was happening, and it was still hard to navigate. Knowing the mechanism does not make the experience easier. It makes it more manageable, but it does not make it easy. What I experienced personally that I want you to know, the hunger that comes with perimenopausal hormonal shifts is qualitatively different from regular hunger. It is more urgent. It has a chemical quality to it, and it does not respond to the same strategies that worked before perimenopause. When I started my GLP-1 medication, one of the most significant things it did was quiet that dysregulated appetite signaling enough that I could actually hear my body's real hunger cues again, not suppress them entirely, quiet the noise enough to hear the signal. But here is what I also learned from personal experience. GLP-1 medications are not doing the work alone. The sleep has to be addressed. The cortisol has to be managed. The protein targets have to be right. The micronutrient gaps have to be closed. The medication works in an ecosystem, not in isolation. When I addressed all of those things together, the results were meaningful and sustainable. When I focused only on the medication, progress stalled. That is the clinical truth I bring to my practice every single day. It is why I am able to work with women navigating this intersection in a way that is both clinically rigorous and genuinely empathetic. I know what this feels like from the inside. Okay, let's get into the practical clinical framework. This is what I actually work through with clients like Michelle and what I apply in my own life. Protocol Pillar 1, recalibrate your protein targets. If you are post-bariatric in perimenopause, the protein target you were given at your surgical follow-up is almost certainly not enough anymore. Here is the framework I use in practice. Minimum starting point is 90 grams of protein per day. For most women at this intersection, I'm working towards 100 to 120 grams depending on body weight, activity level, and how much muscle mass loss has already occurred. And critically, it is not just total grams, it is distribution and source. Morning protein is non-negotiable. I want at least 30 grams of protein before 10 a.m. And here is why. Your body has the highest rate of muscle protein synthesis in the morning hours. If you are eating a light breakfast or skipping it, which many post-bariatric patients do because morning appetite is low, especially on a GLP-1, you are missing the window where protein does most of the work for muscle preservation. Protein source matters for bariatric patients specifically. Dense, dry proteins such as chicken breast, certain cuts of beef, can cause discomfort and slow digestion in ways that reduce absorption effectively. High moisture protein sources such as eggs, Greek yogurt, cottage cheese, salt fish, and protein shakes are generally better tolerated and more efficiently absorbed with altered anatomy. This is not a general dietitian recommendation. This is a bariatric specific one. And leucine, I want you to know this word. Leucine is the amino acid that most directly triggers muscle protein synthesis. It is found in highest concentrations in animal proteins, particularly whey protein, eggs, and dairy. If you're using protein supplements, look for a whey-based option or one that specifically highlights leucine content. This is the amino acid doing the heavy lifting for muscle preservation. Protocol Pillar 2, address the micronutrient gaps. Get your labs done. I cannot say this strongly enough. Annual labs for bariatric patients are not optional, and if you are in perimenopause, your lab panel needs to expand beyond the standard bariatric follow-up. At minimum, I want to see B12, vitamin D, iron with ferritin, magnesium, and a full thyroid panel including free T3 and reverse T3. I also want a fasting insulin, not just fasting glucose. Fasting glucose can look normal while insulin resistance has been building for years. Fasting insulin tells you what is actually happening with your metabolic function. If your magnesium is low or lower normal, supplement with magnesium glycinate, not magnesium oxide, which has a poor absorption, 300 to 400 milligrams at night. Magnesium glycinate crosses the blood-brain barrier more effectively and supports both sleep quality and cortisol regulation. For most of my perimenopausal clients, this is one of the highest impact single interventions I recommend. For vitamin D, aim for blood levels between 50 and 80 nanograms per milliliter. Most people are supplementing at doses that maintain them in the 30s, which is technically sufficient, but not optimal for hormonal regulation and immune function. Work with your provider on this one because vitamin D toxicity is real, but most post-bariatric patients in perimenopause need higher supplementation doses than the general population. Protocol Pillar 3, treat sleep as a metabolic intervention. I am going to say something that might surprise you. For perimenopausal women, sleep optimization is as important as nutrition for weight management. This is not a wellness platitude. This is clinical physiology. When you are in the cortisol disruption pattern of perimenopause, where HPA axis dysregulation is causing erratic cortisol throughout the day and spikes at night, inadequate or disrupted sleep perpetuates the entire cycle. Poor sleep raises cortisol. Elevated cortisol impairs insulin sensitivity. Impaired insulin sensitivity drives fat storage and increases cravings. Increased cravings make it harder to hit your nutrition targets, and harder nutrition adherence leads to poorer sleep. It is a cycle, and you have to interrupt it. Practical strategies that I use personally and recommend clinically. Consistent sleep and wake times, even on weekends. Your circadian rhythm is a powerful metabolic regulator, and it responds to consistency more than duration. Magnesium glycinate at night, as mentioned, keeping your room cool. Thermoregulation is directly affected by regulating estrogen in a cooler sleep environment significantly reduces night wake events. Avoiding screens for 30 minutes before bed is real, not cliche. The blue light suppresses melatonin, which is already less robust in perimenopausal women. And if you are waking at 3 a.m. consistently, do not lie there fighting it. Get up, do something calm and non-stimulating for 20 minutes, then return to bed. Fighting wakefulness raises cortisol further. Accepting it temporarily and returning to sleep is more effective for long-term sleep architecture repair. Protocol Pillar 4. Cortisol management is nutrition strategy. This is the piece most nutrition conversations skip entirely. If your cortisol is chronically elevated, which it very likely is if you're in perimenopause with disrupted sleep, your nutrition strategy has to account for it. Chronically elevated cortisol drives glucose release from your liver. It drives fat storage in your midsection. It breaks down muscle tissue for glucose. The exact opposite of what we are trying to achieve with our protein strategy. You cannot out-eat a cortisol problem. What actually moves cortisol in a meaningful way? Sleep, as we discussed. Resistance training, not excessive cardio, which can further spike cortisol in women who are already stressed, but progressive resistance training 3 to 4 days per week. Adaptogens such as ashwagandha have genuine evidence for HPA axis support. This is not wellness marketing. There are randomized controlled trials, and protein 4 eating actually supports cortisol regulation by stabilizing blood sugar, which reduces one of the primary triggers for cortisol. For Michelle, once we addressed her magnesium, tightened her morning protein, and she started a consistent resistance training program, her 3 a.m. wake-ups reduced from nightly to 2 to 3 times per week within the first month. Her cortisol was still dysregulated, but we had interrupted the worst of the cycle. One more layer I want to address because it is increasingly relevant. GLP-1 medications in the context of bariatric surgery and perimenopause. More and more post-bariatric patients are being prescribed GLP-1 medications. Ozempic, Wegovy, tirzepatide for weight regain or weight management in the years following surgery. And this is a legitimate clinical approach. But there are specifics that matter. GLP-1 medications work in part by slowing gastric emptying. They slow down how quickly food moves through your stomach. Bariatric surgery has already altered your gastric anatomy and motility. Stacking a GLP-1 on top of that creates compounded slowing of gastric emptying. For some patients, this is beneficial. Extended satiety, more manageable portions. For others, it can cause significant nausea, reflux, or discomfort. If you are post-bariatric and starting a GLP-1, this interaction needs to be on your and your provider's radar from day one. GLP-1 medications also reduce appetite significantly. For post-bariatric patients who are already eating smaller volumes, this can make hitting protein targets extremely challenging. Low appetite plus small stomach plus GLP-1 appetite suppression equals significant risk of inadequate protein intake. This is where I see the most dangerous gap in practice. Post-bariatric patients on GLP-1s who are losing weight rapidly but losing muscle along with fat because protein intake has dropped too low. Rapid weight loss without adequate protein in a post-bariatric patient on a GLP-1 can be clinically significant. My personal experience on tirzepatide, my appetite suppression is real and meaningful. There are days where I have to eat by the clock rather than by hunger because my hunger signals are quieted enough that I would undereat if I relied on them. I set reminders. I prioritize protein at every eating occasion, regardless of hunger level. This is discipline in a different form than most people expect from weight loss medication. Not resisting the urge to eat, but remembering to eat enough of the right things, even when you don't feel like it. For perimenopausal women specifically, GLP-1 medications interact with the hormonal environment. I will do a full dedicated video on this, but estrogen fluctuation affects GLP-1 receptor sensitivity. This is why some women experience periods where their medication feels less effective, not because the medication stopped working, but because the hormonal environment shifted. This is not a reason to automatically escalate your dose. It is a reason to look at what else is happening hormonally and address those variables first. So here's a summary of what I want you to walk away with today. If you are post-bariatric and in perimenopause with or without GLP-1, you are navigating an intersection that most providers are not trained to see as a whole. That is not your fault. And the fact that your labs look normal does not mean everything is fine. It means your providers are looking at a piece of the picture. The full picture includes your protein absorption and your updated protein targets. It includes your micronutrient status beyond the standard bariatric panel. It includes your sleep and what disruptive sleep is doing to your cortisol and your metabolic function. And it includes your hormonal environment and how that environment is affecting every other system we just talked about. This is workable. Michelle is doing significantly better, not because we found one magic answer, but because we addressed the whole picture systematically. You deserve the same systematic approach. Now, I have 3 ways you can go deeper from here. First, I have a matching blog post for this video that goes even further into the clinical detail. If you are someone who likes to read, highlight, and take notes, that blog post is waiting for you. The link is in the description. Second, if you are ready for ongoing clinical support, community, and monthly deep dives exactly like this one, I want to invite you to the Real Talk Continuum membership. This is not a generic wellness membership. This is a space built specifically for women at the intersection of bariatric nutrition, GLP-1 therapy, and perimenopausal metabolism. You get direct access to me as your RDN, a community of women who actually get what you are navigating, monthly clinical content, and resources built for your specific anatomy and hormonal stage. The link to join is in the description. Third, if you are ready for individualized one-on-one support where we build a protocol specific to your labs, your surgical history, your hormonal picture, and your goals, my one-on-one coaching application is also in the description. I work with a limited number of clients at a time so that everyone I work with gets the attention this level of complexity deserves. Share this video with a woman in your life who is post-bariatric and in her 40s, because I promise you, she has been looking for exactly this conversation and does not know where to find it. I'm Tradena Rayner, registered dietitian nutritionist, and I'll see you in the next one.